Good afternoon. I'm Carolyn Meltzer, Dean of the Keck School of Medicine of the University of Southern California. It's my pleasure to welcome you to today's event, The Physician as Advocate: From Clinical Excellence to Policy Impact. I want to thank my colleagues at the USC Institute on Inequalities in Global Health for working with me on this important panel. Thank you to Dr. Wes Mizutani and Dr. Linda Mirdamati for your visionary leadership and commitment to USC. It's often said that an ounce of prevention is worth a pound of cure. As a medical school dean, I want to pose a question. Is an ounce of good public policy worth a pound of good clinical care? After all, public policy shapes the conditions in which we practice medicine and conduct research that leads to new discoveries. Just like preventing disease is better than treating it, influencing public policies works upstream from delivering and improving clinical care. As a radiologist, I know this all too well. In order to effectively care for patients, it helps me to understand and help shape the rules that govern care. Laws around the use of artificial intelligence in radiology may influence the quality of care I deliver. Regulations that govern the private sector's role in healthcare may play a role in the clinical decisions I make. Levels of public financing for healthcare determine whether I have to make difficult choices about patient access. In all of these areas, my clinical experience is an asset at the policy table. If I'm trained and equipped to communicate with lawmakers, regulators, and appropriators, our laws, regulations, and funding levels will likely be stronger and fairer. This is why at the University of Southern California, we're investing in policy literacy for our students, trainees, and faculty. Our medical students want to write policy papers and raise their voices in support of access to healthcare. Our residents want to solve policy problems and do rotations at policy organizations. Our faculty want to write op-eds and testify in front of congressional committees. We owe it to them and to our community to support and equip them to do just that. We're convening today's coast-to-coast event in two locations: our home at the USC Health Sciences campus in Los Angeles and our new Capital Campus in Washington, D.C. In Los Angeles, we have a long tradition of bringing our clinical and research excellence to bear on local and state policy. In Washington, D.C., our Capital Campus creates a historic opportunity to scale this legacy at a federal level. The timing couldn't be more urgent. Steep cuts to Medicaid and biomedical research, disinformation about vaccines, and narrowing opportunities for medical education all demand a strong policy voice. The stakes are too high to exclude medical experts from the policy debate. Fortunately, USC is not alone in recognizing the role of policy in medical education. A growing number of undergraduate and graduate medical programs are integrating policy curricula and experimenting with policy electives. Some professional societies offer policy fellowship opportunities in addition to standing policy committees and advocacy days at local, state, and federal levels. Yet these efforts remain fragmented and underfunded. As medical schools, we need to embed policy into the core competencies and career pathways of our students and physicians. We need to develop sustainable pathways for policy work in the research, education, and clinical domains. We need to create opportunities for all to meaningfully engage in public policy discourse. At USC, our North Star is academic excellence. That makes policy engagement part of our job, not something we leave to others. Some of the greatest strides in medical progress have occurred when clinicians team up with other disciplines: attorneys, economists, political scientists, social workers, all together to solve health problems that transcend sectors. That kind of collaboration and innovation is at the heart of what we do. Thank you for joining us today and being part of it.
Well, welcome, everybody. Good afternoon. Good afternoon here in Washington, D.C. Good afternoon in Los Angeles, where we have a simultaneous broadcast. My name's Jonathan Cohen, and on behalf of the Keck School of Medicine at the University of Southern California and the USC Institute on Inequalities in Global Health, and also on behalf of my co-moderator, Dr. Taylor Burkholder in LA, we want to welcome you to the Physician as Advocate, from clinical excellence to policy impact. It was, I believe, in this very room about a year ago that Dr. Wes Mizutani, who is a proud alumnus of USC's Dornsife College, a former resident at the LA County USC Medical Center, met with our president emerita, Dr. Carol Folt, on the occasion of USC's first homecoming event on this beautiful new Capital Campus. Wes shared with Dr. Folt the kernel of an idea, which is to leverage our presence here in DC to connect our medical faculty to the heart of federal health policy making by training our physicians to translate their clinical and research expertise into policy impact. That idea is now becoming a reality, and that is in no small part thanks to Wes's generous financial support to create a physician advocacy program that will put USC at the center of this dynamic space. Thank you very much, Wes. It is also in no small part due to the leadership of many others who have helped to nurture and develop this idea, including, of course, Dean Carolyn Meltzer, whom you'll hear from in a moment, Professor Sophia Gruskin, the director of the USC Institute on Inequalities in Global Health, Brian Kennedy and Josie Cooper, whom you'll hear from the Alliance for Patient Access, Dr. Glenn Alt, USC's Senior Associate Dean for Graduate Medical Education, Dr. Jeff Rydell, our Assistant Dean for Medical Student Research, Betsy Jaffe at the Keck School of Medicine of USC, just to name a select few. Thank you to all of you as well. With the support of this incredible group, we have begun designing and implementing physician advocacy programs for our USC medical students, trainees, and clinicians. And as you can see, we are proudly using this incredible campus in Washington to convene, nurture, and activate people who support and believe in the physician's role as a policy advocate. I have the pleasure of introducing, along with Dr. Burkholder, 4 panelists who will join us in this discussion, 2 here in Washington, D.C., and 2 in Los Angeles, who you'll see in a moment. We just have to zoom in and put them on the screen. Their full bios are in the digital program. If you didn't have a chance to scan the QR code near the coffee table, please do so. But let me just offer a few highlights, and then I'll turn it over to Taylor Burkholder. So first, I want to introduce Dr. Wes Mizutani to my immediate right. Wes is a highly accomplished and indeed award-winning rheumatologist in Southern California, who's held a number of senior roles, including with the Talbert Medical Group, where he's overseen more than 100 clinical trials in addition to his medical practice, as well as the Optum Medical Group and the UCSD School of Medicine. Of particular relevance to this event, Dr. Mizutani is a board member of the Alliance for Patient Access, which is our co-sponsor today, among a number of other volunteer roles. And he has testified at legislative hearings in both Washington, D.C. and in Sacramento. And Wes is also the recipient of 2 recent important awards, the California Chronic Care Coalition 2024 Star of Advocacy Award, and the Lupus Los Angeles 2025 Medical Visionary Award. So welcome, Wes, and thanks for being here. And just for our tech crew, we don't see the LA feed quite yet. I think they're working on it. Seated next to Wes is Josie Cooper. Welcome, Josie. Josie, you and I share the distinction of being the only 2 non-physicians on today's panel, or medical students. Josie serves as executive director of the Alliance for Patient Access, where she mobilizes stakeholders and clinicians and develops policy and educational strategies to improve patient access to care. She has a long and impressive background in communications, research, grassroots organization, and campaign politics. Prior to joining the Alliance for Patient Access, Josie worked for a Washington, D.C. based consulting firm, as well as for a trade association representing biotechnology companies. Welcome to USC, Josie. And hopefully the tech will allow me now to turn it over to my colleague, Dr. Taylor Burkholder, in Los Angeles to introduce our LA-based panelists. Taylor is himself an accomplished physician advocate. He serves as an associate professor of clinical emergency medicine at the Keck School of Medicine of USC, as well as the director of academic programs at the USC Institute on Inequalities in Global Health. And so we will turn it over to Taylor once, and it's possible that the LA crowd will hear him before he does, so please bear with us.
In addition to chairing the National Policy and Advocacy Committee for the National Hispanic Medical Association, she also serves as the faculty advisor to our Latino Medical Students Association here at USC. So welcome, Linda. And last but not least, of course, is Venela Devanavoyina, who is a second-year medical student here at Keck School of Medicine and recently completed our Keck School of Medicine and IAGH Global Health Policy Scholars Program this summer in Washington, D.C. Venela is a passionate advocate for health policy and the role of physicians as actors of political change. She co-founded the Policy Pulse, a Keck School of Medicine student organization created to engage health professionals in discussions at the intersection of healthcare and advocacy. So thank you for being with us, Venela.
Thank you.
Give it just 1 minute and turn it back over to Jonathan once the tech situation has been worked out. And for anybody here in LA that hasn't had a chance to get refreshments, please feel free to do so.
All right, Taylor, I think. Hi, Taylor. Hi, Venela. Hi, Linda.
Hello.
Hey, Jonathan, are you able to hear us now?
Okay, we hear you. We see you. Thank you. Thank you for those introductions. So back to Washington. I'm going to open the panel. I hope you can hear us and see us with a question for all of our panelists. Wes, we're going to start with you. I'd like to ask each of you, just to kick us off, to share with us a personal experience or a memory that persuaded you that physicians can play an influential role in public policy development. Wes, let's start with you.
This is on?
Yeah.
Okay. Well, thank you, Jonathan. First, let me thank Jonathan for he's humble and he didn't really take any credit for this whole program. But I got to tell you that a year ago when we started talking about this, I really never thought it would happen in this year. I think maybe next year or the year after. And for Jonathan to put all of this together in such a short period of time and get all of the people here together on the panel as well as in the audience, just amazing, and congratulations, really a great job. So to answer the question, I'd like to take you all back to the early 2000s. Now, if you're a medical student, probably were in preschool, so you probably don't remember too much about that. But in any case, one of the things I remember were some songs, and songs during that time. One of them you may recall was "Toxic" by Britney Spears, another being "Hey Ya" by Outkast. You remember those? And it's probably more familiar to me than to most of you, just because I recently saw a play called Anne Juliet. It's a play in which they use music from the 1990s and 2000s and integrate it into the story of Romeo and Juliet, which is a little different. So I highly recommend it if you have a chance to watch it. But I digress. During this time, a very important bill was presented in Congress, and it had to do with appropriating funding for the National Arthritis Action Plan. This would fund a public health strategy at the state level by building, developing, and implementing arthritis control and prevention programs. State health departments would receive the funding to enhance state level programs to reduce the burden of arthritis within each state. For you historians out there, the bill was named HR 1283, entitled Arthritis Prevention and Control and Cure Act of 2008. And the lead sponsor, for those of you that are history buffs, was Representative Issue from California. There was also a similar Senate bill that Senator Edward Kennedy sponsored. And I vividly recall going on Capitol Hill, and I was a little intrepid about this visit because we actually had a visit with Senator Harry Reid, who at the time was the Senate Majority Leader, right? And he was a big, senator, in terms of his power. And so there were a couple, that was one reason I was intrepid. The other reason was that I wasn't his constituent, obviously from California. We did have a couple of people from Nevada, but as not being constituent, it does sometimes make a difference when you're talking to senators and congresspeople. So, and the third thing was when I walked out of the office, there was a lobby group that had MGM on their shirts. And I go, great, we just followed the MGM lobbyists and how much money they have to give. So we sat down, we got to the office, we sat down with the health aide, and we were in a big table, which I thought was interesting because usually we ended up on the stairwells or in the middle of the lobby or in front of the door. But it was nice. And so we were talking about 5 minutes, and then all of a sudden the senator walks in. And I thought, oh, he's just going to pass through and go to his office. But he actually sat down with us, and he actually asked to introduce ourselves, which we did. And he said, continue with your presentation. So we continue with our presentation about how important this bill was for arthritis patients, for just the public health programs in general at a state level, and so forth and so on. And then after our presentation, he said, that was a very good presentation. I will definitely think about co-sponsoring your bill, and which is what we had requested him to do. So about 2 days later, we got a mail. In those days, they didn't do emails. So 2 days later, we got a piece of mail that said that he had approved. He decided to co-sponsor the bill. A month later, it was passed by both Congress and signed into law. And so it was a very big deal because those programs in public health at state level continued up until actually this year, where unfortunately it was defunded.
Thanks, Wes. Josie, you would have a different perspective on this, but an equally important one. Any particular memory that persuaded you of the physician's advocacy role?
So a couple, and as I start, maybe it's helpful to give like a just quick who's AFPA, because I'm not sure everybody knows. So Alliance for Patient Access, we are a national nonprofit organization that works to equip healthcare providers and other advocates we work to equip them to be policy advocates. So we are nearly 20 years old, and we work to empower, folks to engage at a federal level, at a state level, at a health plan level in policy conversations related to patient access and patient-centered care. And one of the things that I love about AFPA, you mentioned I'm not a physician. We were co-founded by a physician with this core belief always that physicians and other HCPs have a really important role in advocacy. And so, we have always been persuaded that physicians are important in advocacy. We continue to be physician-led. Our board is entirely comprised of healthcare providers. But two things that I'll say that kind of personally convinced me is one, we did some research, some polling a couple of years ago looking at who is trusted in the healthcare system. So who is viewed favorably, so we could think, okay, who's the best messenger for some of these issues? And, it's not insurers, it's not, not-for-profits, it's physicians and it's nurses. And so when you think about, okay, who should be engaging in policy, it's all of you because you have public trust and clinical expertise and patient stories. And so it's really just harnessing that to make sure that folks have, opportunities to do it effectively. The second is one thing that we have learned as we're taking physicians around Capitol Hill or into a state legislature to testify or do a meeting or whatnot. We're often bringing the only physician voice into that conversation. When you're, state capitol and you're hearing people testify in support or in opposition to a bill, it's a lot of lobbyists for insurers and PBMs and the pharma companies. It's not often that clinician voice. And so I've really always been struck by that because it makes that voice so much more meaningful and so much more important. I was thinking about an instance not that long ago where we brought a clinician, and I think it was you, Wes, up to a Capitol Hill meeting, and we're talking to the staff about the issue. It was the obesity coverage bill. And the staffer said, you're the first physician we've heard from about this. We've heard from a lot of other people, but you're the first physician we heard from. And I just thought, wow, we need to expand that. We need to make sure that, there's more people involved in this work so that it's less rare.
Thanks, Josie. Let's go to LA.
Did you want to take the next step with that same question?
Sure. First of all, I want to welcome everyone here today. And many of my students are here, students that I've mentored, students that are from ICM. So thank you for joining us. I greatly appreciate it. Before I answer the question, though, really quickly, I just want to acknowledge that it is National Hispanic Heritage Month this month. And so this particular panel is very, very close to my heart as a second generation Latina, as a granddaughter of an immigrant farm worker. Policy is in my blood, it's in my veins. And so I'm really honored to be here. So thank you for having me. So to answer the question, I have so many memories, but I'm going to focus just on one in particular. I'm going to take you back to not the early 2000s, Dr. Luzitani, but I'm going to take you back a couple of years ago to 2023. In 2023, I was named one of 12 National Healthcare Policy Fellows through the National Hispanic Medical Association. And in that year, I had the opportunity to write a policy brief with two other colleagues, present that brief to multiple stakeholders at the state level and at the federal level, meet with many, many legislators, meet with lots of different staff. Often the staffers are the most influential people in the office because they're the ones who actually write the legislation. I learned that later. But as a result of the policy brief that we wrote on the inequities in access to mental health, that was the area that we focused on, and especially our underserved, our underrepresented, our Latino community here in Los Angeles. So I wanted to bring a voice to Capitol Hill to try and influence policy. And so we went to a hearing that was supposed to be chaired by Bernie Sanders, but Elizabeth Warren stepped in, which was fine. I got to meet her too, but sat in on a hearing on one of her HELP committee hearings. The HELP committee is the Health, Education, Labor, and Pension Committee. It's the most powerful committee in Capitol Hill that oversees anything related to health. And so sat in on that committee, met with her, discussed a little bit about the initiative, but didn't have the time to go into big detail. It was shortly after that we were invited to the White House. Now, mind you, this was under the Biden-Harris administration. So we walk into the Eisenhower building, which is right off the West Wing. Beautiful room, sat in this mahogany floor-to-ceiling room, this big mahogany desk. And I thought, there's only 12 seats around here, right? So I take my seat and in comes walking in this senior advisor to President Biden and his special assistants over health, education, and mental health. And I sat there and they leaned across the table after we did our introductions and basically said, "What can we do for you, Dr. Miradamati?" And I was stunned. It's like, wait a second, I have got an opportunity to really make an impact here. So I'm with my colleagues. There were 12 of us. 12 of us were in the cohort. They were in the fellowship. And I brought the voice from our community there. I brought the voice from our underserved community. I was able to share the disparities that I saw in access to mental health, where the barriers were, the cultural barriers, language barriers, inequities in access to medical care, and then talk about where I thought we could try and make some change. And at the end of the conversation, it came up that I was from USC. And so one of the senior advisors flashed a fight on right there above the table. It was amazing. We immediately bonded. We exchanged information, contact information. I'm still in contact with her today. No longer is she an advisor in the presidential office, I would have to say. But the bottom line is that ignited a fire in my belly. I realized I had an opportunity to come back to California and try and create more change. So I did. And when I came back to California, I immediately realized that we had something that was coming onto the ballot, and that was the MCO tax. The MCO tax is the managed care organization tax that taxes 1% of all healthcare organizations. And the money is supposed to be allocated to go into Medicaid. We call it Medi-Cal in California. The carve out of about $7 to $9 billion that was at risk at that point. The carve out was that there was a certain number of dollars to go to mental health advocacy and access. And so I jumped on that. So I partnered with Governor Newsom, I partnered with the LA County Medical Association and the California Medical Association and helped push that through. It was on the ballot last November, 2024. It was known as Proposition 35, and it passed. Overwhelmingly, it passed. More than 70% of Californians voted for that. So that taught me a really big lesson, is to identify an issue and then follow something through and identify policy. And so I would have to say that full circle event that I just explained was probably the most memorable and got me fired up. And I'm still going today. So thank you.
What phenomenal stories, Linda. Thank you so much. And speaking of fighting on and affecting change, I'll turn it over to Venela to share her personal experience there.
Yeah, thank you. So I think for me, I'm going to go back to when I first realized that health policy is kind of what I wanted to do. I think since that moment, there's been so many moments that have affirmed it, but I think that first moment for me was so impactful. So it goes back to my freshman year of college. And like any college student, I came in thinking I'm going to major in one thing. And I was like, okay, this is not for me. I didn't know what I was thinking when I was 17. So I got to do the fun thing of when you're pre-med, you can major in anything. So I was like, okay, let's explore. And I took an economics course taught by the amazing Martha Only back in UC Berkeley. And I remember we had a lesson, this was a couple weeks in, where we were reading an article about healthcare and about the costs of healthcare. And, you know, it doesn't necessarily fit into this stereotype of economics and the free market, because you're like, oh, what does healthcare have to do with it? And I think that's when I realized in our country, healthcare is treated as a product of the free market, and it doesn't work that way. You know, I believe that healthcare is a right, and I don't think rights should be marketed for supply and demand. And that's exactly what health economics says, is that the normal models of supply and demand don't work for healthcare because everyone needs it, everyone has it, and it goes down over time. And I think that like juxtaposition and that like incongruence with that reality is what made me realize like, oh, people who are in medicine should be thinking about this, because this is just like Dean Meltzer said, is the upstream of what we all interact with later on in our day-to-day. So I think realizing that, oh, this is a place where I can impact change on a wide scale, and that impacts all of us. I'm sure many of you who went to college were then realizing, how am I going to get healthcare? If you went to college out of state, your health insurance likely didn't cover you. So you're left with this point where it's like, if I need to get a flu shot, if I need to get a vaccine, if I need to go get a blood test, I'm paying hundreds of dollars. And I think that was the reality I was presented with when I was in my freshman year of college. And it's still been going. USC has been a great place for that. So yeah.
How about this amazing leadership we're seeing from our medical students at USC? Thank you, Venela. Thank you, Linda. Thank you, Wes and Josie. I want to follow up with Wes and Linda as the two practicing physicians on the panel. Each of you has alluded to work with medical professional associations. Linda, you've talked a lot about the National Hispanic Medical Association, who partnered with us on the event. We have leadership and staff from NHMA here with us in Washington, D.C. We join them in celebrating Hispanic Heritage Month. Wes, of course, you and Josie talked about the Alliance for Patient Access. You know, a lot of people would say the professional associations are taking care of this. They're taking care of the advocacy piece. Why do medical schools have to get involved in this? And I'm curious what your experience advocating with and through medical associations has taught you about what you think the role of medical schools should be in developing physician advocates? Start with you, Wes.
Okay, I'll be brief, getting on like the last question, because Vanilla and I will talk a little bit more about this in a couple minutes. But I did want to talk about my experience with young physicians who are in practice that I see going through our clinic all the time. And one of the things that's always kind of shocking to me is how they really don't understand how the policies that dictate whether patients gets care, access to care, medicines or whatever, they don't understand how that was decided. Like, who decides this? Why can't I get this patient this drug? And then when you combine that, because they obviously haven't gotten any information through medical school residency, what have you, and you combine that with seeing 35 patients a day, they're overwhelmed. So where are they going to find the time? And they don't know about advocacy. So where are they going to find the time to do that? So that's why I think it's important that at medical schools curriculum, that it becomes part of a core curriculum, that public health policy and advocacy becomes part of, because not only does it affect the way physicians can advocate for patients in their office for, getting, filling out prior auths or getting on the phone for trying to argue with the medical director whether they should get this treatment or this medicine or not. But it also means that once they understand advocacy, they can actually help the patient be a better advocate for themselves. And that is where it's very important.
Thank you. We may want to come back to that. Linda.
So, yes, so thank you. So the story that I shared earlier about the work that took me from, the local, state, and federal advocacy and the policy brief, after the Proposition 35 passed and all the excitement that was around that, I was thrilled and humbled and honored to be appointed to a couple of very significant boards to continue that work. And so those are the organizations that I currently work with. So I am serving on the board of the LA County Medical Association. We're the largest medical organization, county medical organization in California. And, we serve over 10 million people in our county. So you imagine how many patients we have and how we need to get physicians involved in the organization. Also, this year, I was elected to represent the state of California to the American Medical Association's House of Delegates. And the House of Delegates is the healthcare policy arm of the AMA, the most influential health policy arm in Washington, D.C. And so I'm able to help shape policy at the local level through LACMA, through CMA, which is the California Medical Association, and AMA. Not to mention, as what Jonathan Cohen mentioned earlier, as I'm also on the board of the National Hispanic Medical Association, and I chair their National Policy Committee. So with all that being said, that all happened in the last 2 years. In 2 years, I made all of that happen. And it's not just me, it took a family, it took a network, it took mentors to move in that direction. But the point I want to make is that you can do it too, and we need your voice. And you don't want to wait until you retire like I did to get involved. We want to get students involved early on in their education. And I also want to mention LACMA, the CMA, and the AMA, and NHMA. We all have medical student memberships. We all have medical student sections where you could be represented. We all have opportunities where you can get involved in shaping healthcare policy. You represent your constituents. Your constituents are your colleagues. Your constituents are going to be your peers in medical school. Where do you see the policy needs to be created? Where do you see the unfairness? Where do you see where there's an opportunity to make an improvement in your medical education? So we need your voice. We need to partner. So to go back to Jonathan Cohen's question is, how do we see this partnership develop? I think we have an incredible opportunity with academic medicine and medical organized medicine to partner together, but we need you and we need your voice, and we need to start the training. We need to start civic training in elementary school, in middle school, in high school. then we need to continue it on. And I think Dean Meltzer said something that was very poignant, and that is policy engagement is part of our job. We're physicians. This is part of our job. So I think it's extremely important. So thank you for being able to answer that.
Thank you for sharing, and it's a perfect segue into my next question for Venela, specifically having established the importance of this education early on. Let's talk about the demand side as well, coming from medical students. So Venela, when you were applying to medical schools, how much of a priority was it for you to have public policy as part of your medical education? And how did you think about pursuing that?
That's a great question. I think I will say I came a little bit from an untraditional pathway in that I did have that background in economics and policy. And I think that really drove my interest. So for me, it was very important. And I think there were several ways that I went about looking for that. I know like when you apply to medical school, they have like those databases with all the schools, and they actually will like list certain things about the school. One of them is if they offer dual degrees. So something that I looked for was whether they had like MPHs or MPPs. And that said a lot to me about what kind of students are they trying to attract. I think the second thing is like looking at the actual curriculum on their pages. Something that stood out to me about USC is they very widely broadcast the physician, citizen, scholar. I think the citizen word, and it kind of heralds back to this idea of civic duty that we owe our patients. And I really resonated with that. And I see that also with USC's like health justice and systems of care class that we all do take. And I think there's another way to also approach that is I think, Dr. Miramati hinted at this, is as physicians, we're advocates at an individual level when we have a patient-physician interaction. We're advocates at this national and federal level when we go to the Hill or go to our state legislators. But we're also advocates at this community level. Like when we see many patients in a day that all have the same issue, we see a pattern, we're in charge of then taking that pattern and saying this needs to be solved. And so I think something that was really important to me was seeing medical schools that were engaged with their community and not just, okay, we do amazing research, but we also then take that research and we apply it to the communities around it. Because I think that's public policy. So yeah.
All right, I've got a follow-up question for you, Venela. Tell us a little bit about what you learned about the physician's role as an advocate while doing the USC Summer Global Health Policy Scholars Program this past summer.
Yeah, so I was with the amazing Maureen Lewis, who's all the way up there in the crowd. She was my fellow policy scholar. And I think something we constantly talked about was we would come back from a day on the Hill and just like be analyzing the fact and processing the fact that we were just on the Hill. Like I think for the average medical student out there, I don't think they have these opportunities to take what we do from the day to day and then take it and go and be in these really amazing spaces that I know Dr. Mizutani and Dr. Miramati have been in. So I think that was a huge thing, was realizing that that is an opportunity for you. For me, I'm like the daughter of Indian immigrants. And so being a doctor already was like not something I ever even imagined, but then to also then take my experiences and have people in Congress at the national level then take that and put it into policy was incredible. It was a level of advocacy that I didn't really even imagine for myself. And I want to speak that because it's something that, like Dr. Miramati said, is so easy for us to do. And when we go into these rooms, we come in not just as any old constituent, we're coming in as physicians who are representatives of our communities and our patients, and that's huge. I think something else I learned is the language of healthcare, the language of medicine, and the language of policy are very, very different. So when you're going to someone and you're like, well, this is what the science says, in policy, they're like, okay, what does it mean for me? Like, what do I get out of that? And I think that is unique. You can't just say, this is the evidence, of course, this is the answer. You have to really speak this language of, what is your stake in my answer? Like, why do you need to care about what I'm saying? And I think that's very different from medicine and the way that we're trained. I think coming from my undergraduate career as a political economist, I was like trained in how to talk like that. And then 1 year medical school erased all of that. And all of a sudden I didn't know how to speak that language anymore. So something I really realized is it is something that we need to be thinking about and actually integrating into our health education as, aspiring physicians.
So, Wes, let me jump off that. You've heard a bit about experiences that Venela has had in medical school, what she was looking for in a medical school. I'm curious, when you were a medical student, what kind of opportunities did you have to engage in public policy, and what kind of opportunities maybe do you wish you'd had?
Well, thanks. I think back recently about people always ask me, well, today, would you go into medicine again? Or would you do the same thing if you had a chance? And sometimes I think about, well, maybe I would and maybe I wouldn't, just because of the way medicine has changed in terms of healthcare policies. And you really can't, as a physician, you're not able to really do what you want to do sometimes, or what you think the patient needs. But then I think back to what Vanilla just said, and I think that if I had the opportunity to learn about advocacy in medical school, I think that would by itself, to me, stimulate me to go back into medicine, because I think that is where you can affect change. Back when I went to medical school, which no, I didn't go to medical school with Jonas Salks. Sorry. But there was no, I liken healthcare policy education at that time to kind of rheumatology. So when I went to medical school, the only way you got rheumatology training was if you did an externship. There was no core curriculum. It wasn't even in medical school, really. And the same thing with healthcare policy, although it's even worse because couldn't even find where to go. So, I mean, you didn't know where to ask to go get healthcare policy training or anything unless you did like an internship up at the Hill, which obviously would take you longer than 1 month or 1 month rotation. So there really wasn't anything out there. What I wish there was, because when I got out of medical school and began my practice, I was like all the physicians nowadays, they don't understand, well, why can't I get this patient this drug? What's step therapy? Why do I have to go through this? And so I didn't have the answers for that. And it was very frustrating. And also it took me 7 years, much like Dr. Marley, it took me 7 years to actually get somebody contact me to say, hey, would you like to do this? I was fortunate enough in 7 years that a lady named Vicky Fung, who is currently the executive director of vice president of the Arthritis Foundation, she asked me to join a panel group of senior physician advocates. And we sat down one night. It was a rainy night. I remember it was in the middle of Carson. And at that time, Carson wasn't the best place to be. So we all worried about whether we got our cars back out when we left the meeting. But in any case, so the meeting was about trying to develop a policy or some kind of committee in the state of California that would focus on advocacy for arthritis. And so what we came up with is what is now known as the California Arthritis Foundation Council, which basically advocates on the state level for all arthritis patients.
Thanks, Wes. So Vanilla, let's go back to you. So you've heard a bit about what Wes experienced. Obviously, you had this incredible opportunity this past summer, but how much do you think things have changed or not?
Yeah, I think, like I mentioned before, we do have opportunities to talk about the downstream effects of health policy. So like social determinants of health, how does zip code impact health? All these different things I think we do get to talk about in our curriculum, which is amazing. But we don't talk at all really about the upstream impact and what our role is in that. So we don't get to talk about what is the exact policy that makes it so that certain patients don't get access to certain drugs. We don't get to talk about how can we enact change in that way. And that's not, I think like Dr. Mizutani said, you can do like an externship. You can go out of your way and you can find these opportunities, but that means that every single medical student is not getting the same standardized education on health policy. So that's a lot of missed opportunities to create physicians that are important in these spaces. I will say an example I can give is I came to medical school and within like a month realized with a couple other classmates that we had no idea what each other's political opinions were on things like health policy. Like we didn't even know if other people felt like healthcare was a human right. And that's crazy that we don't even know that about each other and that's not even discussed in our education. I think it's kind of seen as it's not a physician's duty, even though, like I said, I do believe it is part of our responsibility. So that's kind of why what led me to starting the Policy Pulse was creating this space for us to discuss our political opinions in terms of how it impacts our role as physicians and what we can do to enact change. So I guess my answer to that is that it hasn't changed a lot. It's changed in some ways, but I think in the very pervasive, way for like every single medical student, it's still really difficult to get these opportunities.
Thanks, Manila. Wes, one more question for you on this line, which is, I suppose if we did carve out more time for medical students to do the kind of learning Venela is describing, to learn about upstream policy determinants and to learn how to act on them, some people would say, well, that's less time learning about clinical care. That's less time learning about biomedical research, and that's going to compromise their technical abilities. What would be your response to that?
First, let me just say that if we would solve the public health policy advocacy issues if we could clone Venela.
Here, here.
But anyway, let me get back to so I think that one of the fallacies or myths, as it were, in physician advocacy is it takes a lot of time. Okay, it doesn't. Some organizations, many organizations, the nonprofit health organizations, have sent out action items or action letters to physicians or to their constituents, patients otherwise. And all it takes is a physician to put their address in, put their name in, put their zip code in, because we need to know who's your constituent, and send a letter. You may not think that's a big deal, but when you multiply that times 50,000 or times 1,000 in the state, it makes a big difference. And the nice thing about that is, believe it or not, you actually get a reply from the legislative office that says, thank you. And after that, you actually keep getting letters from them asking you about policy issues or whatever, or things like that. So it's something that you can do that doesn't take a lot of time. Another thing that doesn't necessarily take a lot of time are things like op-eds and letters to the editor, in which if you belong to a nonprofit, a lot of the nonprofits have people that can help you write some of it. And what you do as a physician is you put your own story in it, and then you just sign it and send it off. And those can be very effective. So it doesn't take a lot of time. It's a myth, I think.
Thank you. Let's go back to LA.
Thank you, Dr. Mizutani, for those wonderful examples of some relatively low-hanging fruit to get involved and stay involved, even when you're busy with your clinical learning. Dr. Miramati, I'd like to turn over to you as one of the people on the panel with the perspective as someone who teaches medical students, many of which are here in our audience today. I've got a kind of multi-part question for you. What appetite do you see among your students to engage in policy and advocacy? And what types of opportunities have you found for them, or do you lead them to currently? And the final part of that question is, if you were able to design your ideal curriculum or training program, what might you include in it?
Okay, that's a lot to unpack. So we'll start first with my students, ICM, and kind of the curriculum that we teach. And one of my ICM colleagues, instructors, is here too, Dr. Mary Casa. She can attest to this. So we really emphasize in our training in ICM to bring awareness to the social determinants of health every time we see patients. So whether we're seeing a patient at the Keck Hospital, which is our private hospital, or we're at LA General, we often have conversations, and my students will ask me, why is this person unhoused? Why is this patient keep bouncing back through the ER? Why can't we fix this problem? And I always, turn it back to them and say, well, what do you think we ought to do? And how can we change policy? And I emphasize to all of my students, and I'm sure they could attest to this, they probably get tired of me saying this, but I truly believe that all policy is health policy. And the reason being is because if you're talking about economic policy, if you're talking about global policy, it all affects social determinants of health, which are the drivers of health that affects health outcomes. And look at what's happening right now with our current administration. Look at HR 1. I mean, I could go on and on and on about the Medicaid cuts and how that's affecting. But I think that the appetite is there. I think students might feel reluctant to talk about it, as Vanilla said. That's just the awareness and feeling comfortable and having this safe, what I like to call the safe psychological space that allows my students to feel comfortable, to have discourse and to talk and have discussion. But I will have to say that I do believe there is a really big appetite. Now, when I am on my various conferences that I do attend, when I'm at the AMA House of Delegates conferences, I see in the medical student section a lot of representation from UCLA, from Stanford, from Kaiser Permanente, and I'm scratching my head going, where are our Keck students? Why aren't our students here, right? So my call to action to every one of you that are here, those that are interested in advocacy, is to join organized medicine, whether it's the LACMA, CMA, or the AMA. Again, this is where you could take this curriculum that you're learning through your social justice program, through your JEDI program, and make it more actionable. You could really do that. For the second part of the question is, how would I create a curriculum? I probably would mirror it after my NHMA fellowship. And I had an amazing experience. It was a one-year experience, and maybe it can be condensed into a semester, but I would want to make sure that it is a program that's available for our students, whether it's going to be required or an elective, that it be a didactic as well as an experiential program. I also would love to have the opportunity to break our students into small groups, not to do it alone because it's too much, but break it down into 3 to 4 students per group and have them assigned an issue, or they identify an issue, a public policy issue, a public health issue that is really personal to them, that they feel passionate about, and have them help them write a policy brief. With that, I would assign a faculty advisor who's an expert or somebody who has experience in policy writing, and help that student group, small little cohort, build that policy brief. But don't end it there. As part of building that brief, you need to do a lot of research, a lot of investigation, and you're going to meet with stakeholders. What do I mean by that? It could be legislators, it could be federal agencies, it could be state level agencies, it could be our county agencies, but meeting with stakeholders to get their input so that you understand how health and public health works. And then I would say also have an opportunity to present your findings to a legislator or to an aide, and to really advocate for how you think that issue needs to be resolved that you have identified in that public policy brief. And I would say even take it a step further, take it to the Hill. We go to Capitol Hill and we meet with our representatives. They are so wanting to meet with us. I cannot tell you how Adam Schiff will take an appointment. Alex Padilla will take an appointment. Raul Ruiz, who's one of our representatives in the Inland Empire, will take an appointment. These representatives have a large constituency that are underrepresented, that depend on public health policies, and they're not experts, with the exception of Raul Ruiz, who's an ER doctor. But the majority of these congressional leaders that we have, both at the state capitol and in Congress, at the Capitol Hill, they rely on us as their subject matter experts. And so I would love to design a program that would take it from the classroom didactics to experiential and help nurture that. And then I would say one last thing is, through that 1 month experience, or not 1 month, I'm sorry, 1 semester experience or 1 year, I would also help them identify what bills are currently, what bills are making their way through the House that's in alignment with the policy that they are very passionate about, and let them follow how a bill becomes a law. I mean, that is really the most exciting part. So if you want to get something started, I'd love to be a part of it.
Wow, Linda, and if I could turn the clock back 17 years and start med school again, I would gladly join this program. And with that, I'll turn it back over to DC and Jonathan's next question.
Thank you, Taylor. Josie, I'm really looking forward to hearing how all of this lands with you because I'm so taken with the Alliance for Patient Access because you've understood for so long the physician's role. And as we think about mobilizing and educating our physicians to be policy advocates, we want to learn from you. I mean, how have you gone about doing it? Because you're training physician advocates, you're bringing physicians to the Hill. How do you do it?
So a couple of things. I mean, one I think is separating the individual advocacy that you mentioned from the policy advocacy. Sometimes we talk to folks and we say, we're an advocacy group, and they go, well, I'm doing my peer-to-peer, and I'm doing the appeals process, and I'm talking on the phone all day to insurers, and that is advocacy. That is amazing work that we're so grateful for. Our job at AFPA, and we always try to be really clear with folks, is we do the policy piece. So we take it back a step and say, okay, why do you have to do that peer-to-peer? Why do you have to file that appeal? It's because of these processes. And so you have to kind of make that piece clear and make it clear to physicians why you really need to engage in that piece of the puzzle. And then, we try to make it clear to anyone who's interested in AFPA that you can do as much or as little. You talked about folks don't have a lot of time. And so we try to make advocacy really easy and really accessible. So there's a couple things that AFPA does to mobilize clinicians effectively. The first is advocacy education and training. We spend a tremendous amount of time doing advocacy training for physicians. We do web-based training where we say, hey, we're going to have a program on X part of the policy process, come join us, learn how you can engage in the process. But we also fly clinicians into DC for trainings. We actually just this weekend hosted a working group meeting here in Washington where we brought in about a dozen healthcare providers in the respiratory space. And we spent, a day and a half with them walking through, what they're seeing in clinical practice, how it relates back to policy, and then walking through exactly, what is happening in Washington, how you can engage, what's happening at the state level, how you can engage. And so you have to make it accessible and bring advocacy to very, very busy healthcare providers. So that's our goal, is to make it easy to engage. So we do that, education, that training, but then we also we see ourselves as matchmakers to the actual policy opportunities. We know everybody has different time constraints, different interests, different strengths, that they want to build on. And so I think one thing that AFPA does well is we try to match folks to what's of interest to them. It's not a one-size-fits-all approach. Policy takes a lot of different forms. And so if you want to, do what Dr. Mizutani mentioned and sign your name to a letter, we will help you do that. If you want to fly into DC and do a day's worth of meetings, in your congressional offices, we'll set them up for you. We'll walk around with you. We'll prep you to make sure that you have everything you need walking into those meetings. Our goal is just always to equip the right messenger with the message and the tools and the training to be effective, and then, step back and let our members do their thing.
Thank you. Just following up on that, I'm wondering what your recommendations or even your asks are of medical schools, because you see physicians presumably after they've graduated. So in light of that experience, what, if it were up to you, what kind of policy advocacy training would you like to see medical students and trainees getting during their education?
So much more than they seem to get. I'm so grateful for what you all are doing, because I think it's so critically important. A lot of times when we, bring physicians in to DC and we're training them up, and we've got people who are early career, we've got people who've been practicing for decades. And what we hear a lot of times from our folks who are like early career, they're, new out of med school or soon, a couple years out, is, I wish I would have learned this in med school. I wish I'd known where all this came from, before I was dealing with this mountain of paperwork and all these denials and this battle between the insurer all the time. And so, I think making advocacy, making policy training a core part of the medical, education is critical, because you got to capture folks and help them understand what they're in for and how they can make a difference early before they get out of school and then are hit with all of these barriers that maybe they weren't equipped or trained for. So I'd love it to be a core, part of the offering. I'd love for medical schools to partner with, organizations like ours, other organizations that do this, all day, every day, to, maximize what we can do. Because I just think there's a huge need, and, it just has to be addressed.
Thanks. Did you want to add anything before we go back? Use your mic. Just thinking.
Used to the lavalier. Just that I have to echo what Josie said. I think that what AFPA does is a very unique thing in this town and in the state legislatures too, is that when I go to some of these conferences, we have these young physicians, maybe 3 years, 4 years out. And first of all, they sit there like in awe of the stuff that goes on in Capitol Hill or in their state legislatures, that they had no idea this policy was present. And they go, a light bulb goes off and says, oh, so that's why I can't get that drug. And they go, darn it, we're going to do something. I need to do something about that. And it's just so stimulating to see young physicians to get that kind of stimulus to want to do something. And I think, why can't we shift that 4 years or 5 years before into medical school curriculum?
We're getting lots of good ideas. Taylor, back to you.
All right, I have one very minor, not loaded question for all four panelists to wrap this up. So we'll start over here in Los Angeles with Venela and move on to Dr. Miramati. But two-part question for you. Where do you think the physician's voice is particularly needed in policy and advocacy today? And can you share an example that will persuade the currently practicing and future physicians in the audience that their voice will make a difference?
Okay, a little challenging that the answer is everywhere. But if I had to choose one spot, I think it's that the belief that healthcare is political, and the belief that physicians and healthcare workers are political actors. And uniquely so, because we see so many people, we interact with communities and we see patterns. And like Dr. Miramati said, all policy is health policy. And so when we see these things in health, it's because of upstream patterns that are political often. And so I think that shift where it's no longer seen as, oh, I'm a scientist purely, it's evidence-based. None of this is, it doesn't exist in a vacuum. It exists in the context, and the context is political. So I think that is like where I would say is the biggest shift. And I think that's the biggest roadblock I run into. There's a lot of medical students that I talk to that are like, why do I need to engage in this? And it's like, oh my gosh, we need to start from step one here. And then your second question was, can I share an example that will persuade? I think the thing that's first coming to my mind right now is the second years at Keck right now are learning about psychology, psychiatry. And I think something that I've heard a lot from my fellow students is how like disillusioning it can be that when you have people who present with these really intense, severe symptoms, and a lot of times the etiology of their symptoms isn't some like genetic disease or genetic mutation. It's the social context. It's the homelessness. It's the lack of access to food. It's the lack of access to shelter. And those are not things that you can prescribe an SSRI and say, okay, bye, right? And those are things that feel very like the moral injury is intense when you're not able to give a cure to something like that. And you know what? In other countries, they are able to give a cure to something like that because there's better social programs and there's better systems that are there. I'm not saying our country's so far behind and that another country's perfect, but we have a long way to go in terms of recognizing that role. And so I think that's would be my example of where we can persuade it is I think physicians share these stories and we see these things in a way that's very intense and very impactful in legislative spaces, but also just when we're in the community and we're taking the time to do that. I know it's not seen traditionally as a role of a physician, but I would really, really challenge my peers, fellow medical students, but also physicians out in the field today that like that is something we should be taking on.
Thank you, Vanilla. Over to you, Linda.
Okay, so as I said before, I truly believe that all policy is health policy. And I do also believe we all have a role. I like to say we could take our stethoscopes from our exam room where you are all advocates, but one-on-one, to a boardroom to help influence change, to Washington, D.C. And you could really, really create that change. We have to create a pathway to do that. I think everybody is well aware of the current political environment that we're living in right now and how changes that affected the passage of HR 1 and how that's impacting disproportionately our community here in LA. Our underserved community, our under-resourced community, HR 1 has really gutted Medicaid across the nation. Medi-Cal in California is what we refer Medicaid to. But again, disproportionately affecting our community here in Los Angeles. We have, 15 million people on Medicaid. We have, majority of women and children. And so this is making an impact, if not on you personally, not on your patients personally, but maybe somebody even in your family, maybe a friend, maybe a colleague, maybe a neighbor. And so with stories like that, I think it's really important to understand that this is really affecting everyone. And the biggest example I would give is that current passage of HR 1. And now people are going to say, well, what are we going to do about it? How are we going to stop it? Well, there is a lot of work that's going on right now behind the scenes with the AMA and CMA and LACMA that I'm involved in trying to see what we could do to introduce legislation to try and slow things down or try and divert funds in certain directions. But I do want to circle back to how students can get involved. The AAMC, the American Association of Medical Colleges, has a physician in training toolkit on advocacy, and it is an amazing, amazing resource. So if any of you are interested, I would definitely tap into that. And then, of course, tap into all the organized medicine and the organizations that I've mentioned. But I think that we all have a lot of work to do, but we are all our advocates, whether it's in our community, as Vanilla said, whether it's in our family, our community, in our county, the state, or at the federal level, we all have an opportunity to make a change. So thank you.
Over to you, Jonathan.
So I'm gonna pose the same question to each of you, and Josie, I'll start with you and give you the last word, Wes. But before I do, we do have time for questions. There's a microphone there. So once we've heard from Josie and Wes about where they think the physician voice is particularly needed now, and we are here in Washington, D.C. having this discussion, we invite you to come up to the mic. You'll need to use the mic in order for LA colleagues to hear you, and we have plenty of time for questions. So Josie, where do we need physician voices now, and what persuades you that that will make a difference?
So I'm biased because of where the Alliance for Patient Access spends most of our time, but I think it's access policy, it's health insurance reforms. When we talk to healthcare providers, across the country, no matter where they're at, no matter their specialty, the number one frustration we hear is I can't get the care I believe is clinically appropriate to my patient because of a prior authorization or a step requirement or, a cost sharing challenge for the patient. And so I see that as a core area of physician advocacy and a huge need and a huge opportunity because there are state level opportunities, there are federal opportunities, there are bipartisan opportunities. That's, pretty rare, to do this work and to make it easier for a patient to get what they need and for you all to do your jobs effectively. And one thing that drives, I think, our belief in how important this is we did a survey a couple of years ago on the role of kind of these health insurance barriers on physician burnout. And we looked at, how much time are you spending in your practice, dealing with the paperwork versus providing care? How much time are you spending at night on the weekends dealing with this? Does it take you away from your family? Does it make you less interested in staying in medicine? And, our physicians said, yes, I mean, we're spending all of this time, we're getting more and more burned out because we can't, do our jobs the way we want to do, the way we know is best. We can't get our patients what they need. That creates huge mental challenges for folks. And so, all of these issues are driving physician burnout, too, at a time where we need more physicians. And so I think it's a really, really urgent issue to address. So that's, I guess, one. Why do I think, or what's an example of where I think we can be effective? So I'll share one. I mean, I can share dozens of areas where AFPA has been able to make an effective policy change, but a recent one was with the Centers for Medicare and Medicaid. So we advocate at all levels. We deal with Medicare and Medicaid policy frequently, and we do a lot of work in neurology. So situation was, new Parkinson's medication was approved for patients in more advanced stages of the disease, an area with high unmet need. And doctors were thrilled about it. I talked to our chief medical officer, who's a movement disorder specialist. He was thrilled about this new treatment and what it could do for his patients. Patient groups, patients were excited. And the coverage policies lagged, and then they lagged a little longer and a little longer. And so patients, didn't have a clear path to getting a treatment that everyone involved was excited about. And so we, along with a handful of other partners, met with CMS, a whole range of folks from their team maybe a month ago. And we brought, our physician voice to that meeting. It's not me talking about it. It's, a physician coming in to talk about the need for coverage for this therapy from their clinical perspective. And he talked about, what the disease is and how it advances and why a medication like this fills a gap and what it means for his patients to get coverage and what it means when they don't. And CMS really, really responsive, seemed quite appreciative of the meeting. And lo and behold, a couple of weeks ago, they announced it's a draft, but then they announced the draft coverage determination for the medication, and it's good. It's good. Physicians and patients will have a much clearer path to access. So there's lots of examples like that. But that I think was really powerful because it actually happened quickly too, which is exciting and not always the case.
Seeing is believing. Yeah. Wes?
I take a little shift here in the sense that I'm looking more of, seems like that the healthcare policy legislative determinations have been kind of on a state level more so than they have been in the past. And I think that emphasis on a state level gives us an opportunity as physicians to have more impact at a state level and make policy changes on a state level than you would, say, nationally. And I think that what happens when a state, like say California, makes a policy determination that is felt to be, cutting edge and all the patient-friendly, whatever, it tends to boil over into other states. And so sooner or later, you see many states, if not all the states, joining into that whatever that legislation that was passed. So I think one example I can give you, which AFPA helped with a lot, was the biomarker bill that was presented last year in the state of California. And AFPA had done a lot of work about a year before, actually, the bill even came out, to educate legislators about what biomarkers were and their importance in not only cancer, but other disease entities. And then but then you also had the opposition, which is the insurance companies, et cetera, coming in and doing this misinformation campaign where they said, oh, well, we already passed a biomarker bill 5 years ago. Why do we need another one? And the misinformation was that the biomarker bill that was passed 5 years ago only included cancer drugs. It didn't include any other biomarker approval for any other diseases. So rheumatology, neurology, GI, all of the fields where nowadays new biomarkers are coming out monthly to help not only diagnose patients, but also help to determine what treatment is best for them, can't be more approved. So with cooperation with Josie and AFPA, we did several things. We did an op-ed, we did a webinar for all the state legislator aides, and it was very well received. And finally, I testified to the State Health Committee on the biomarker bill. And you had a lot, what was interesting is, you sit at this table, you see the audience up there, but then there's this long line of people that want to make comments. And 90% of the people that were in the long line were from insurance companies. So you can see where that is a problem. So the bottom line is the bill passed. It was the only bill, one of the few bills that actually Governor Newsom signed last year on healthcare policy. So we're proud of that. And it does show you that with physician advocacy on a state level, you can really make a difference.
Thank you. So we have some time for questions. We have a mic here in DC if anyone has any questions. And I believe, Taylor, I don't know if there's a roving mic or a standing mic in LA. People can start.
We have a roving mic given the setup and danger of walking up and down the stairs here, but I will do my best to relay any questions from the LA crew so the panelists there in DC can hear it.
Oh, great. Thank you. Any questions, comments, please? And if you could introduce yourself. Thanks.
Yeah, thank you so much. This has been an incredibly interesting panel. My name is Jane Buchanan. I am the Director of Global Impact for an organization called Help Age USA, and we work on the rights of older people all around the world. And I'm certainly interested in the global angle, but I did have a question for all of you. In terms of advocacy in the US, on the part of physicians for issues that are really kind of health issues that are really at the forefront in the culture wars as well. So we think, for a long time, access to reproductive health. Now it's access to things like gender affirming care, access to healthcare for undocumented folks, even vaccine access. Where maybe the stakes are a little bit different or a little bit higher for physicians to kind of speak out on that. So I'm curious if any of you have experience of that with your colleagues, how you maybe discuss that with physicians, obligations that physicians may feel, balancing their advocacy with their ability to continue to provide care, pursue their professions. Thank you.
Thank you so much for asking that question. I would like to start, if I could, with one of the physicians on the panel, either Wes or Linda, because you have had to think about that in your own advocacy. And then I'd also love to hear how Josie and Vanilla are thinking about it.
So I can go ahead and get started here from Los Angeles. And this is the core of the advocacy work that we're doing. And it's the access to care. And what we're seeing is that, and what we're hearing from our physicians, practicing physicians, especially those in pediatrics, primary care, OBGYN, is we have a large, I can speak for California, we have a large percentage of our patients that are on Medicaid, again, Medi-Cal in California. And with the budget cuts, not only in the state of California, but the federal mandate through HR 1 that has cut access to Medicaid, it is disproportionately affecting our underserved and underrepresented communities. And our physicians that are working in rural communities serving these patients and families and women and children, it's been very difficult because they have a duty. They've taken a Hippocratic oath. They want to provide the care for these patients, but they're not getting reimbursed due to Medicaid cuts. And if more and more of our vulnerable community is not going to have access to healthcare, and our patients can't provide that healthcare because they're not coming in, especially in light of all the immigration issues that are happening right now, all the ICE raids, especially here in LA. I've been hearing from my colleagues here on the ground in LA that a lot of our Latino patients aren't even seeking care. They're not coming in for the COVID and flu vaccines. They're not coming in for prenatal visits. And the reason is because they're afraid. And so what is going to happen if we don't have access and these patients aren't seeking care? We're going to have late delay in diagnosis, right, of hypertension, diabetes. How is that going to affect, the mom? All this prenatal care that can be compromised. So it is a very, very significant. We're trying to get boots on the ground and figure out how we're going to overcome all this without a reverse in these policies. We don't know what we're going to do, but we've got lots of FQHCs, which are the federally qualified health centers that have always been that gap that's provided, the gap in healthcare, that safety net, we like to say. LA General is the same thing. So, we just have to get together between academics, healthcare organizations, organized medicine, and see what we can do to try and affect change.
Mm-hmm. Yeah, but Wes, I want to turn. Oh, Vanilla, did you want to
chime in? I don't know if Dr. Tani, if you'd like to go first.
Go ahead.
Okay. So this is a great question. I think it's kind of elephant in the room. I think my answer to this is a bit complicated, and that obviously I think those of us who are here on this panel are here because we have similar values in the sense of health equity and health access. I unfortunately don't know if I think that's equal around all of medicine. I think the reason that we're seeing, abortion access and gender affirming care being controversial is because people are politicizing these things, and they shouldn't be political. I personally don't believe they should be political, but they're becoming political. And I think what's happening is you also have the general public, but also physicians and healthcare workers also falling into this trap of believing it is political and not a right, and not something that has to do with well-being and mortality and morbidity. It's become something that should be argued about. And I don't think that's the case. I personally don't believe that should be the case, but that is unfortunately what's happening. And so when it comes to conversations around this, my experience is I actually have interacted with more and more people that are afraid to say their opinions because their opinions are political now, and they're not really based in the science and the evidence anymore. And I think that's why it's even more important to encourage these conversations, because so much of what we're seeing right now, I think physicians are humans as well, and they fall into these online echo chambers in the same way that any other person would. And so I think it's important to acknowledge that. And part of that is to be in community and to look into the evidence and to look into those things. So I will say, I do think I've interacted with people who do fall into those traps, but I think there's also just as many people, if not more, who do believe that should be an action, that there should be access to this and are taking actions for that. But it's a slow road. Even though it's so easy to take away these things, it's a slow road to bring them back. But I think there are definitely people, just like Dr. Mirdamati said, who are working at various levels to constantly make sure that access is not being stripped away.
Thanks.
Yeah, that was a great comment, Vanilla. I definitely agree with that. In our clinics, we've been seeing the tragedy that a lot of our Medi-Cal patients no longer can come to our clinic. And who knows where they're going. I think a lot of their care now becomes emergency rooms, which obviously isn't a good thing. And I think that even the Medi-Cal patients that we do have, their formularies have been cut so much they can't even get the medications a lot of times that they really need. So I think, going back to when Dr. Metzger started this conversation, this summit, she mentioned that there needed to be a partnership between patients, physicians, and other advocates. And I really think that this problem is multifaceted, and it needs all three of us to get together and make a push to change or unchange what has been changed. Because otherwise, if we each go by our separate ways, it's not going to get done.
Thanks.
I mean, I would echo the comments of the other panelists. I mean, it's a really challenging time right now in healthcare. It's been challenging for patients. It's been challenging for care partners. I mean, it's really hard here in DC in particular. One thing I've been, to your point about partnerships, really encouraged by, though, has been the number of organizations that are coming together to advocate together on these topics. Physician organizations, patient organizations, care partner organizations, the breadth of the healthcare advocacy community, I think, really has come together and said, okay, where are the opportunities for us? How do we speak from a shared voice so that we're harder to ignore? And I think the more that we can do that, and give these issues faces too, to your point about patients, I think that's at least a path.
Just as a follow-up, and I understood at least part of your question, Jane, to be about whether physicians think that they are taking a professional risk by advocating on these highly polarized issues. And we hear anecdotally that indeed hospital administrators are sort of encouraging physicians to keep their head down, not everyone has to be at the barricades, let's, and stay in your lane, and these kind of subtle ways of discouraging it. And I'm wondering if any of you has a reflection on that, particularly as USC thinks about educating physician advocates. Any reflection on this perception of professional risk?
Well, I really haven't, I mean, working for a corporation, really haven't seen any top-down kind of, dictum or whatever suggestions to not be active. However, I think when, people unfortunately either get shot at or killed or whatever for voicing their political views, it does make you think about, what's going to happen to me if I voice my, and especially if you're someone that's not really used to doing advocacy, it could scare you away for sure.
Thanks for sharing that.
I'd like to add one thing is that we all can confidently vote. So this week was voter registration week. So I hope all of you who are not registered, you did register. And that is one way that you can make your voice heard and help shape, the trajectory of where we're going. And so is to vote. I also wanted to add one thing, and Vanilla had mentioned, that which we all agree is that, healthcare is a right and we should not be politicizing this. I'm going to take a quote that Dr. Diana Romas told me the other day, California Surgeon General, and she says, remember, Linda, health is not just medicine. It's also about culture, community, and compassion. So I think if you remember that, you will unpoliticize all of this and turn back to humanity, human rights, the right to healthcare, and doing the right thing without the fear of any form of retaliation.
Thanks. Let's see if there's a question in LA. Oh, sorry, Vanilla, go ahead. And then we'll see if there's an LA question.
Answer your thing, Jonathan, about like the fear of retaliation and certain administrators saying not to do things. I think obviously being a med student, I'm much less in the food chain. So I feel like I do have to listen when certain people tell me not to do certain things. But I think that's been something that we as students have been struggling a lot, especially like say when the protests were going on earlier this year in LA, like a lot of students were like, I feel like I should be out there, but instead I'm sitting here doing Anki and studying for an exam. And I think a huge thing that came through was that advocacy takes many forms. Like we are able to be here advocating and making healthcare more equitable because our community partners are out there protesting. And one of the best things that we can do as medical students is become great advocates as physicians. And so I think I will like, yes, there is this retaliation. I'm not going to say it doesn't exist. I think people are so uncertain in these times. Like I think anyone doesn't know if they can say certain things, right? So it is there, but I think there's also ways that we work smarter and we work quieter, but we're still doing the good work, so.
Thank you. And Jonathan, we have a question here in Los Angeles from Professor Gruskin. All right, to try and paraphrase the question for those in DC as well, fantastic question about, especially for those that are just getting started in their training and developing into future physician advocates. Where do you go to find that initial training and motivation and the topics of interest that are so relevant to getting your start? We'll start here with Linda and then Vala.
Well, I think, again, I'm going to circle back to organized medicine because we have identified those issues. So NHMA, we have our policy issues, the issues that really matter and affect our community. LACMA has theirs, CMA has theirs, but many of them are all in alignment, including the AMA. We are, dedicated, committed to equity-centered policy. So equity-centered policy. So that's supporting, advancing policy that's going to decrease disparities. And so I would say that would be the first start is by joining the organizations, learning about the policies that we're supporting. Also just finding, looking in your community and seeing what is affecting your community. Whether it's in your medical school training, whether it's at LA General, whether it's here in LA in the state of California, really wherever your passion lies is identifying those areas. And we have plenty to choose from right now.
That's a great answer. I think that's definitely the starting point. I will say for all our healthcare professionals, not just med students, this is for anyone who's interested in healthcare. The Policy Pulse is a club that we started for you to come and talk and connect. We have lots of people like speakers who'll come and speak to us, and we meet like once a month and we literally just talk about that. And because that was something I recognized as I came here and I was like, where do I even start? There's not even a space for this. There's not even a forum. So that's what that is. But I would also definitely encourage, if you don't have an organization like the Policy Pulse in your institution, going to your local counties and whatnot and the medical associations there. I think the first part of your question was also about where do you focus your energy? And I like every 2 years, I have like a whole mental breakdown because I'm like, oh my gosh, there's so much going on in the world. Like I have to go solve this and this and this. And I always have to go back to like, okay, I need to trust that my peers are giving their 100% on the issues that they're going to focus on. So I'm going to focus on X, Y, and Z, and I'm going to give my 100% on this. And it's hard because every time you go to conferences and you hear about all this work, you're like, I want to go back and I want to go do work on that. And you always just have to like go back. I think the big answer to that is community. And I think that's also, again, why I plugged the Policy Pulse, because our point was community. When you're like faced with all these overwhelming issues, community is the source of support. And I think that's like a huge thing we have here in our medical community. Like people in medicine are so connected with each other. And we just want to make that so that they're connected about policy too. And all these overwhelming issues. Yeah.
Yeah, I'd be remiss if I didn't mention involvement in nonprofit medical organizations because medical specialty organizations say. When my mother passed away so many years ago of several diseases, one of them was colon cancer, another was Alzheimer's, I kind of related to what Vanilla was saying that, oh, I want to do this, I want to do that, I also want to do that. But you don't have the time. But what I found was that when you're passionate about something, and you don't have to be in that specialty to be passionate about it. If you have a loved one that has Alzheimer's, then you should be involved with Alzheimer's, society, the nonprofit organization. And that's a way of merging what Dr. Metzger said in the beginning of patients, physicians, and other advocates together at one time. And that has the biggest impact. Josie would, I think, would echo this, both at a state level and a federal level. So that's what I would echo. Looking at, nonprofit organizations, they're easy to find. There's one for any disease you can think of. There's even one now for IgG4 related diseases, thanks to Josie. So you can find them, they're out there, and they're easy to access and so thank you.
It's like the saying goes, what I'm looking for is not out there, it's in me. Yeah, that's where you should look. Josie.
I'll be brief. I'm half joking, but www.allianceforpatientaccess.org. If you're interested in doing advocacy work, we'd love to work with you. If you decide, your passions lie elsewhere, we partner with, I don't know, 150 patient advocacy organizations, nonprofits, med societies across dozens of disease areas, some who are based in DC, some who are based all over the country. So if we're not for you, we're honestly happy to just be a resource in helping kind of figure out where you want to direct your energy. Because, we don't all have to do everything. It's just finding that's something you want to focus on.
Thank you. Question here in DC.
A great conversation. I'm going to go back to coalition building because I think that's so important. And you talked about you could have a voice, like whatever is right for you at a given time as an individual, sending a letter, being part of some kind of organization or professional society. And then comes the coalitions, which can have a bigger impact. And I guess my question about that is, first of all, going on beyond physicians, partnering with nurses and pharmacists and PAs. So if somebody could, comment on coalitions across multiple disciplines, but even within medicine, there's lots of differences in terms of priorities. And then I just like people to hear a little bit more about effective coalition building within medicine, across medical disciplines, and then beyond to the community.
Thank you for that question. Yeah.
That's an excellent question because if you belong to one nonprofit organization or another, individually, there's not much one organization can do. In the state of California, there's a Chronic Care Coalition that is a very powerful organization throughout the state. And I don't know how many members they have, but they probably have over a couple hundred. And part of the biomarker bill that I talked about, the Chronic Care Coalition of California was a big supporter and they helped us push it through. So there are, and Josie can probably tell you more about different coalitions on the federal level, but certainly at the state level, there are the Chronic Care Coalition, there are other coalitions, but Chronic Care is probably the largest one in the state. And they encompass a whole umbrella of different organizations. And we have a meeting next couple of weeks where a lot of the member organizations will come to this, all different disease entities, physicians, non-physicians, nurses, what have you, and just talk about policy for next year. And so it does happen, fortunately, enough that we can get legislation passed, but maybe Josie can say something.
Yeah, I love the question. I think it's a really important question. We, to your point, Dr. Mizutani, we all can't do everything. And so coalition work is really important to move policy. Our organization is a part of a number of coalitions so that we can expand our reach. We also lead coalitions to bring folks together. Some coalitions are focused around one policy, some are focused around a disease area. But the goal is always, as many voices as you can on one kind of area, but just expanding what you can do. One example I'll give just briefly is COPD policy. So we at AFPA launched a COPD coalition, the COPD Action Alliance last year, because the state of COPD care is incredibly challenging. It's not a disease that has been prioritized at a federal level or at a state level. If you talk to a state policymaker, they don't even necessarily know what it is. And we're talking about the sixth leading cause of death in the United States. I mean, it's shocking to me. And so the goal for us in bringing together a coalition was to make sure that everyone who has an interest in this disease for one reason or another, could have a seat at the table as it relates to policy. So we have provider organizations, we have patient organizations, we have representation from rural health and communities of color who are disproportionately impacted, and women who are disproportionately impacted, because you've got to make it clear to policymakers the breadth of the issue, and coalition work, I think, is one of the best ways you can do it. So I appreciate the question.
Thanks. And before we go to LA, the techs can hear us. We're getting a note that the confidence screen is going to power off if we don't press a button. And we would hate not to be able to see our LA colleagues. So if you heard that and can refresh our confidence screen, that would be great. Any comments in LA on the question about coalition building?
I mean, other than I just echo what was
Thank you.
said, is that, can you hear me, Jonathan?
Yep, we're all set.
Yeah, just to echo what everybody else said, it's really important to build those coalitions, and it's important to do it across the, you know, the nonprofit, the public-private, academic, and organized medicine, and happy to see that NHMA and USC is going to be doing exactly that. We're very excited about that. So if any of you are going to be in LA on September 27th, I'm going to put a plug in for our National Latino Physician Day. You do not have to be Latino to come. It's just supporting the diversity in the workforce and bringing awareness that we really need to work and collaborate together to diversify our workforce. So September 27th on Saturday.
Is there a question in LA?
Here in LA. A fantastic question that I'll try and paraphrase for those in DC here, primarily around the issue of degrading trust in physicians with current discourse, echo chambers, et cetera, and wondering how physicians can recuperate some of that trust so that not only when they're speaking to lawmakers, policymakers, but also speaking to the general public to garner their approval on policy. How do we go about fixing that issue?
That's a great question. And I know one thing that NHMA has launched this year is that we have national webinars and podcasts. And a lot of the webinars, subject matter that we've been really promoting is campaigns and awareness. So vaccines is the big one that we're focusing on right now. So there is a lot of misinformation. There's a lot of anti-science out there. You know, we're in a new era of the internet, and there's a lot of misinformation. 20 years ago, 30 years ago, we weren't dealing with this, and we are now. So we have more and more physicians that are on TikTok. We have more and more physicians on social media. But as organized medicine with NHMA, we're doing our best to try and to rebuild that trust and doing these educational webinars. So great question.
Yeah, that's an incredible question. Something I think about a lot. I will say I don't have any like big leap full answer. I think I have little baby steps maybe. And I think one of them is definitely like on the physician-patient interaction, taking the time to understand what is being misunderstood. And I think that can be really hard in our healthcare system where you have like 40 patients a day. But I think that is definitely something every physician can do the best of their like ability. I think making sure that, you know, resources are available in different languages, you know, there are simple things like that. I think on the broader scale, definitely like as Dr. Miramati said, I think we're in an unprecedented time where we don't know where people are getting their information from. And also like once someone is seeing information in a certain way, like the amount of distrust they might feel with authority sources like physicians can be completely different. So I don't have an answer to that, but I think I'm an optimist and I'm thinking, you know, maybe we will get an answer in the future. But I do think like also I think one of my thing is our education system and the amount of people that look at information and think critically about like the credibility and all these things. And I think it comes down to a breakdown in that basic thing that I think used to be a thing. Like you now go to Google and you search it and you just look at what AI says. You don't even look at where is the source coming from? Is it even real? Right. And so I think those simple actions of questions are, I think, a huge cultural thing that unfortunately I don't think physicians alone can fix. And I do think that goes back to our coalition building, interacting with communities and engaging with different people in different sectors, because it's not a one piece fix problem.
Yeah, I echo what Vanilla said. I think a lot, especially her comment about, I think she hit nail on the head when she commented about the physician-patient relationship. I think it really has a lot to do with communication between the physician and the patient. And yes, you may have 35 patients a day, but there is a way to communicate with that patient, even if you only have 5 minutes or 10 minutes, to make them feel important. It can be as little as remembering who they just had a grandchild the last week or something, or just writing it a little note. That's very important, and I think that will build back part of the trust. But I also think that when patients see a physician as an advocate, not that we do it because of that, but when patients see a physician advocating for something that hits their bottom line, they have a whole different look at you in terms of, boy, he really cares, or he really makes a difference. And I think that's a way of tying advocacy to this patient-doctor relationship.
100% agree with that comment. Just really quickly, so a lot of what folks have talked about comes down to like being accessible to people. So being accessible and talking to someone in a language they understand when you're doing a patient visit, being accessible through, the webinars that folks are doing. One thing we try to do is go where people are. So when we do a patient poll or a survey, a lot of times we ask folks, even in the demographic questions, where are you getting your information? Are you getting it from video? Or are you getting it from YouTube, TikTok? Is it all social media? Is it your friends? And then you have to go to where they're getting the information, be accessible there. It's not enough anymore to, publish a paper on your website and go, okay, hopefully people get there. You need to be on social media talking to people where they are. You can't expect folks to come to you. I think part of advocacy is going to where they are.
So we have one more question in DC. If there's another one in LA, I suggest we take two at once and then give the panelists an opportunity to respond to both and make any concluding remarks. And if not, we'll just answer this one. Dr. Burgos.
Hello, everybody. My name is Dr. Gilbert Burgos. I am an internist by training, a physician executive, and I'm also the president and chairman of the board of the National Hispanic Medical Association. So I'm really happy to be here along with everyone else today. I wanted to make one comment. I think I want to compliment, and I'm not sure I'm saying your name correctly, Vanelli, the medical student, because I think you're trying to get at something that I feel very passionate about. And I've had the pleasure as an executive to work in different parts of this country. And at one point I worked in Detroit. So as you may know, we're really right across from Canada. So I had a lot of interactions with Canadian consultants of one sort or another. And to this day, I never forget what one of them told me. He said, you Americans are crazy. In our country, it's really hard to get a gun. It's a privilege to get a gun, but healthcare is a right. He said, in your country, getting a gun is a right, getting healthcare is a privilege. And that is at the core of this. The problem we have is that we think it's a privilege. So if it's a privilege, it's actually something that can be easily taken away. You can easily become unworthy of getting it. And that's what you're seeing right now. All the work that has been done to try to expand getting people more healthcare is slowly being financially sucked out. So that people actually are going to start losing their healthcare, whether it's through Medicaid or whether it's through the Affordable Care Act, by not getting the subsidies. And that's a serious issue. So to me, I think, the problem, though, just to be clear, is that the healthcare industry actually, for the most part, does not support that idea. So I think, again, what she was saying is absolutely right. There are many physicians that do not support this. There are many, many, many in the healthcare industry that do not support the idea that every American should have access to healthcare. That should be a right. I feel very strongly about that. And I also want to comment on what Dr. Binamali said. In the end, you know what? you can vote. If you really don't like what's going on, you should take the responsibility to make sure not only that you vote, but that you go out into your communities and you talk to the people in your communities and you let them know that they have a right to vote, because obviously we are in a very difficult time in our country.
Thank you, Dr. Burgos, for that call to action. Let's go to LA. If there's another question, let's hear it. And either way, let's have a concluding comment from each of our panelists there, and then we'll come back to Washington. Taylor.
Any other questions from the audience here in LA? I think there are no further comments here, so we can just wrap it up with a farewell comment.
So, Linda, Venela, any reactions to what you just heard about healthcare as a human right, or thoughts that you want to leave our audience with today?
So yes, so first of all, this was an amazing bi-coastal event. Thank you so much, Jonathan, for putting this together. And Dr. Burgos, it was wonderful to hear your voice. I couldn't see your face, but great to hear your voice. I do want to put in a plug for the LA County Medical Association. We have what we call a legislative day. We usually hold it in the spring. I try and bring and rally up as many medical students who want to come. So any of you who are interested, feel free to reach out to me. Feel free to join LACMA. And it is a really wonderful day to go up to the state capitol to see this work come to action and to fruition. So thank you. It was a wonderful event.
Thank you so much for that comment. I think it was Dr. Burgos. I'm sorry if I pronounced that wrong. Absolutely. And if anything I can leave you all with is that healthcare is a human right, and we might not be there right now, but let's be optimistic, because optimism is probably the only thing that's going to get us through this time. That we will get there one day. And even if not, we're taking the baby steps. You know, huge change doesn't happen over days. It happens over generations. And I think I get optimistic at the idea that we're creating a world that's going to be better for the generations to come. I think that's kind of what drives me at the end of the day. Thank you everyone so much for coming and, just being here. You being here is you being an advocate. So I really do appreciate that. And again, final plug for the Policy Pulse. I'm also a resource for anyone who wants to get in touch. Yeah, great.
With optimism, we'll send it back to GC to follow up.
Including anything you want to plug.
Well, thank you for the opportunity to be here. I'm glad to be a part of today's event because I and everyone at the Alliance for Patient Access believe very, very strongly in the power of advocacy and the power of physicians specifically as advocates. And so I would just say to, anyone listening, we'd love to partner with you. We'd love to work with you any way you're interested in doing advocacy. It takes a lot of forms, as folks have said, but please, use your voice to advocate somewhere, whether it's, in DC or in your state house or with a different type of policymaker.
Thank you.
Just following up what Vanilla said, my hope and wish is that this is not the end all, this summit. What we hope to do, and Jonathan, myself, and others, Josie and others will be talking about this. We hope to set this up as a springboard to develop more programming for physicians, young physicians, old physicians, whatever, in terms of educating physicians on physician advocacy, getting a program over here in DC that reaches out to practicing physicians that will help open their eyes to advocacy. So I'd like to thank obviously Jonathan and Betsy and Josie and all the people from AFPA for helping this happen, and also Elise, who I don't see her, but helping make the contact with Jonathan and myself to make this thing happen. And I appreciate all the people that showed up today. Thank you for your support.
No, thank you. And I also really want to thank our technical teams. This has been quite a unique point-to-point bi-coastal event. Thank you to Sydney Wally here in Washington, D.C., to Meg Goulding, Caitlin Chang, Linda Rivera. In Los Angeles, there's really a whole team behind this. Thank you so much to all of our panelists. Thank you, Taylor Burkholder, for moderating. with me. And I'll leave you on the same note that Wes did. This isn't just a panel. This is really it's part of an initiative. It's the beginning of something. I think everything that we were hearing gave us ideas and food for thought about how we can design a physician advocacy program throughout the whole pathway, from even before medical school through undergraduate, graduate medical education, training, and medical professionalism. So thank you all very much. I'll ask our techs to thank you to Zoom also to turn off the Zoom and encourage you to have another cup of coffee if you want and network. Thank you all.